You know that moment as eye doctors, when a parent walks in, maybe looking a little defeated, holding their child's latest prescription thicker than the last, and asks, is this it? Is the train just going to keep on rolling with this myopia? It's a question we all grapple with, right?
Absolutely. And that constant search for, well, more effective ways to manage myopia progression in our young patients is what fuels a lot of the research out there, which brings us neatly to the heart of our discussion today.
Yeah,
A really intriguing recent study that explores combining two of our current strategies.
exactly. We've been diving deep into the atropine and spectacle lens combination treatment. That's the ASPECT study published in the British Journal of Ophthalmology. Lead author Noemi Gooms-Vilhos, their aim was pretty clear, wasn't it?
Yeah, it was. They wanted to see if pairing low-dose atropine with those specially designed DIMS spectacle lenses offers a better outcome than using, the same low-dose atropine, but with standard single-vision lenses.
Right. And this is something you, our colleagues, will probably find particularly relevant. We're always looking for ways to optimize our myopia management protocols, aren't we?
For sure. And this study provides a compelling look at a potentially more powerful approach. The key finding, which we'll unpack in detail, showed a significant difference in how much the eye grew the axial length elongation between the two treatment groups over the 12-month study period.
Which is huge.
It really is. This
Yeah.
isn't just a minor adjustment. It could be a real game changer, potentially.
Okay, so let's set the stage a little first. We all know myopia is on the rise globally. It's not just a refractive nuisance, is it? It increases the risk of some serious ocular conditions down the line.
Definitely. And we're already using a few different tools to try and slow its progression, lifestyle recommendations, pharmacological interventions like atropine, and those innovative optical lenses, including the DIMS design.
That's right. Both low-dose atropine and DIMS lenses have shown promise as individual treatments. Atropine's been around for years. We know it can slow progression. And DIMS lenses, with their clever design.
Yeah, those multiple lenslets creating what we call myopic defocus in the periphery.
Exactly. They've also demonstrated effectiveness in reducing axial elongation. Think of those peripheral lenslets as gently, nudging the eye to grow less.
Right. But the data on combining these two approaches has been, shall we say, a bit thin on the ground until now.
And that's where the ASPECT study steps into the picture. So tell us about how they actually conducted this research. What was their methodology?
Well, this was a robust study, a randomized controlled trial in RCT. That's really the gold standard for this kind of research. It helps us have more confidence in the results. It was conducted at the Hospital Clínico San Carlos in Madrid, Spain. The researchers enrolled children between 4 and 16 years old. They had myopia ranging from 1 gauge of 1200D to 90 to 6.0D with limited astigmatism, so less than or equal to 2 diopters. And crucially, they also had to have documented evidence of myopia progression in a year just before joining the study.
So they were definitely progressing already.
Exactly. And they excluded kids with conditions like strabismus, binocular vision problems, previous eye surgery, or any history of using myopia control treatments. So, yeah, they focused on a group already showing that telltale progression.
Right. A specific group already on that myopic trajectory. So how did they divide these participants, and what were the actual interventions?
Okay, so they randomly assigned the 111 participants in a 1.1 ratio to 2 groups. Group A got 0.025% atropine eye drops nightly use, both eyes, along with standard single-vision spectacle lenses.
Standard SVs. Yeah.
Group B also got the same 0.025% atropine nightly, but were fitted with dim spectacle lenses, specifically the MyoSmart lenses from HOI.
Ah.
And to ensure consistency, the atropine was all sourced from the same compounding pharmacy. They even tracked things like when the atropine was dispensed to help monitor adherence.
Good point.
And they used questionnaires and phone check-ins to sort of keep tabs on compliance, too.
Those details really underscore the rigor, don't they? And for those who might need a quick refresher, those DIMS lenses have that central clear zone for distance vision, surrounded by those multiple tiny lenslets.
Yeah, create the peripheral myopic defocus, yeah.
Exactly. A plus 3.5D, a relative positive power in those segments, I think. It's like the lens is giving the eye mixed signals about its growth needs, kind of.
Precisely. And both groups received custom-made plastic lenses, and the spectacle frames were actually kindly donated for the study.
Nice.
The follow-up schedule was the same for everyone. Initial measurements at baseline, then visits at 6 months and 12 months, with a phone call check-in around the 3-month mark as well.
Okay. And at each in-person visit, they took a comprehensive set of measurements.
Yep.
What exactly were they measuring? The usual suspects for a myopia study, I imagine.
Absolutely. They measured best-corrected visual acuity, distance, and near. Critically, they performed cycloplegic refractions using 1% cyclopendolate, to get a really accurate measure of the spherical equivalent refraction, our standard measure of myopia.
Right. Got to relax that accommodation.
Yeah, exactly. They also measured the axial length, the length of the eye front to back, using a precise optical biometer taking multiple readings for accuracy. And because atropine can affect pupil size, they even measured pupil diameter under different lighting conditions to see if there were any correlations. And importantly, the clinicians taking all these measurements didn't know which treatment group the child was in.
Ah, the blinding. Crucial.
Very crucial, yeah, to prevent any unconscious bias from creeping into the results.
Okay, so the main things we're looking at were how much the myopia changed the SER and how much the eye physically grew the axial length. After those 12 months, what did they find? Did the combination, the atropine plus DIMS lenses, show a real benefit?
They did indeed. So out of the initial 111 participants, 102 completed the full 12-month follow-up, which is a pretty good retention rate.
Yeah, that's good.
And when they analyzed the changes in axial lengths, the difference between the two groups was statistically significant. Very significant, actually. In Group A, the atropine with single vision lenses group, the average axial length increased by 0.18 millimeters over the year.
Okay, 0.18.
But in Group B, the combination group with atropine and DIMS lenses, the average increase was only 0.07 millimeters.
Wow, okay, 0.18 versus 0.07.
Yeah, that's a mean difference of 0.11 millimeters, and statistically, that's a very strong finding. The p-value was less than or equal to 0.001.
Okay, that's a pretty substantial difference in the physical growth of the eye. But wait, didn't it get even more interesting when you looked at how many kids didn't progress at all in terms of axial length?
Absolutely. This is a really striking finding. They discovered that a significantly larger portion of children in Group B, that's the combo group, showed no measurable increase in axial length over those 12 months. That figure was 39.6%.
Nearly 40%.
Exactly, compared to just 12.2% in Group A, the atropine plus single vision group.
Wow.
That difference is also statistically significant. It's almost as if the combination therapy helped to, well, put the brakes on eye growth entirely for a good chunk of these kids.
That's a huge percentage in the combination group where the eye didn't lengthen. What about the actual prescription change, the spherical equivalent refraction? Was there a similar significant difference there?
Well, interestingly, the difference in SR progression between the two groups wasn't statistically significant. Group A, the single vision group, showed an average progression of -0.19 diopters.
Okay.
Group B, the DIMS group, progressed by -0.09 diopters on average. So there was definitely a trend towards less myopia progression in the combination group, but it didn't quite reach that statistical significance threshold, the p or 0.05 value.
Huh. So it seems the lenses, when combined with atropine, might be having a more pronounced effect on the physical stretching of the eye than on the refractive error measurement, at least over this initial 12-month period. That's a key distinction.
It seems that way, yeah.
They also looked at specific progression thresholds, right? Like kids who progressed by a certain amount.
Yes, they did. They looked at the percentage of children who progressed by at least 0.2 millimeters in axial length and those who progressed by at least 0.5 diopters in SER, sort of clinically meaningful cutoffs.
Right.
And they found that a significantly lower percentage of children in Group B, only 20.8%, progressed by that 0.2 millimeter axial length mark compared to 40.8% in Group A. So again, favoring the combo group for AL control.
Okay.
However, when they looked at the 0.5D progression in SCR, there was no significant difference between the groups.
So again, the axial length seems to be the more sensitive indicator here, showing the added benefit from the DIMS lenses when combined with atropine.
It really points that way in this study.
Were there any other factors they examined that might have influenced how well the treatments worked? Things like age or family history of myopia?
Definitely. In their multivariate analysis, they found that being in the older age group within the study, specifically those aged 11 to 15 years, and being in Group B, the combo group, were both associated with less axial elongation.
Interesting. Older kids did better.
In terms of less elongation, yes. Also, their initial axial length was a significant factor. Those who started with longer eyes tended to show more progression, which makes sense.
Yeah.
And similarly, the starting level of myopia, the baseline SER, was a predictor of how much the prescription changed over the year.
Okay. What about parental myopia?
Ah, yes.
Yeah.
Interestingly, while having two myopic parents showed a trend towards faster SER progression in the initial, simpler analysis, This didn't remain statistically significant when they considered all the other factors together in the more complex model.
Right, sometimes those initial trends wash out. And what about pupil size? Since we know atropine dilates the pupils, was there any correlation between how much the pupils dilated and how effective the treatments were? You'd think maybe a larger pupil might interact differently with the zones of those DIMS lenses.
That's a very insightful question, yeah, given the optical design.
Yeah.
However, this study didn't find a significant association between changes in pupil size and either the progression of myopia, SER, or the elongation of the eye, axial length, in either treatment group.
Oh, really? Okay.
Yeah. So while the hypothesis is plausible, the data from this particular study didn't support a strong link there.
That's good information to have. And practically speaking, what about safety and how well the kids tolerated the 0.025% atropine dose? That's always a concern for us in clinic.
Yeah, absolutely. Overall, the 0.025% atropine was found to be well tolerated. There were a couple of participants in Group A, the single vision group, who discontinued the study due to side effects they attributed to the atropine.
Okay.
In Group B, the DIMS group, 2 children needed to be switched to photochromatic DIMS lenses, likely to help with increased light sensitivity, which, can be a known side effect of atropine.
Sure.
But generally speaking, this low dose appeared pretty safe and well tolerated over this 12-month period.
Okay, so putting all these pieces together, the combination of low-dose atropine and DIMS lenses seems to offer a real measurable advantage in slowing down that crucial axial elongation. How do these findings stack up against what we already know from studies that looked at these treatments, on their own?
That's a really important point for putting these results into context. When the researchers compared the amount of axial length change in Group B, the combo group, with findings from other studies that used DIMS lenses alone in both Asian and European children,
Right.
the Aspect study actually showed even less elongation with the combination therapy. This certainly suggests a potential additive or maybe even synergistic effect when the two treatments are used together.
So potentially better than just the lenses on their own.
Potentially, yes. And similarly, while the change in prescription, the SER, wasn't significantly different between the groups in this study, the trend towards less progression in the combination group kind of aligns with the idea that a multi-pronged approach might offer a more comprehensive benefit.
It's almost like they're tackling the myopia from two different angles simultaneously. The optical strategy of the lens and the pharmacological effect of the atropine? Maybe a case of two heads being better than one when it comes to keeping myopia in check.
That's definitely the leading hypothesis. They also compared the results of Group A, the atropine-only group in this study, with findings from the well-known LMP study, which investigated different concentrations of atropine.
Yes, the LMP study.
And the results were broadly comparable, which lends further confidence to their findings here. And when they looked at the existing, albeit limited research on other combination therapies, there was a retrospective one using 0.01% atropine plus DIMS in Asian kids, and a non-randomized one in European kids.
Okay.
This study, using the slightly higher 0.025% dose, seems to indicate perhaps even more promising outcomes, although, you always have to be cautious making direct comparisons across different studies with different populations and methods.
Of course, apples and oranges sometimes. And they did the math to calculate those percentage reductions in progression, didn't they? We often see those figures cited.
They did, yeah. They reported a 61.1% less axial elongation and a 54.7% slower myopia progression in Group B compared to Group A. However, the researchers themselves, and this echoes recent guidance in the field, rightly cautioned against relying too heavily on these percentage reductions alone.
Why is that?
Well, because they can sometimes be really influenced by the baseline rate of progression in the control group. If the control group progresses slowly, the percentage reduction looks huge, and vice versa.
Right. The starting point can really skew those numbers. Makes sense. So they also discuss possible reasons why this combination might be more effective. The idea about the atropine-induced pupil dilation may be enhancing the DIMS lens effect, allowing more peripheral defocus onto the retina.
That was a potential mechanism they considered, yes. But as we discussed earlier, their analysis didn't actually find a significant correlation between changes in pupil size and the treatment outcomes in either group in this study.
So still a bit of a question mark there.
Exactly. So while it's a plausible idea, this particular study's data didn't strongly support it. The exact mechanism behind this potential additive effect, well, it probably warrants further investigation.
Now, what I found particularly interesting in their discussion was the mention of the age-matched myopia control, or AMMC system. Can you explain that concept a little more?
Certainly, the AMMC system is basically a way of looking at myopia treatment outcomes by comparing the axial length growth in kids undergoing treatment to the typical physiological axial length growth you'd expect in children of the same age who don't have myopia emetropic children.
Okay, comparing to normal growth.
Exactly. And when the aspect researchers plotted their data using this framework, and a nice figure showing this, figure 3 in the paper, they found that the majority of children in the combination therapy group, Group B, experienced axial elongation rates that were very similar to those of age-matched emetropic children during that first year of treatment.
Wow, that's really encouraging, isn't it?
It's a very promising finding, yeah.
Yeah.
It suggests that the combination therapy might not just be slowing down the myopia, but potentially helping the eye to grow in a more typical non-myopic pattern.
That's almost the ideal scenario, isn't it? To have the eyes of myopic children growing more like those of their non-myopic peers. And the fact that almost 40% in the combination group showed no axial elongation whatsoever over a year, that's a pretty remarkable outcome compared to the single therapy groups in the study and others too. It really makes you sit up and take notice.
It truly does. The researchers highlighted the strengths of their study, the RCT design, including participants from diverse ethnic backgrounds, which could make the findings more broadly applicable.
Good points.
They also acknowledged the limitations, the main one being the 12-month follow-up period. But as we mentioned, they are continuing the study to 24 months, which will provide even more valuable information about the long-term effects. They also considered whether compliance, how well the children adhered to the treatment, might have influenced the results, but they didn't find significant differences between the two groups there.
Okay. So for us eye doctors seeing patients every day, what's the key clinical message from this aspect study? What should we be taking away from this deep dive?
Well, I think the most important takeaway is that this well-designed study provides strong evidence suggesting that combining 0.025% atropine eye drops with DIMS spectacle lenses appears to be significantly more effective in controlling the elongation of the eye, the axial length in children with myopia, compared to using the same low-dose atropine with standard single-vision lenses alone.
Right.
This combination therapy could offer us a more powerful tool in our efforts to manage childhood myopia and potentially reduce the risk of high myopia and its associated nasty complications later in life. It really helps give us a, clearer picture of potential myopia control strategies.
Absolutely. Nicely put. These results certainly give us food for thought when we're discussing myopia management options with parents and thinking about how to best help our young patients. We'll definitely be keeping an eye on those 24-month results.
Yes, definitely.
Yeah.
See what you did there. But yeah, the longer-term data will be crucial for confirming these initial findings and for assessing the sustained effectiveness and safety of this combined approach over a more extended period.
For sure. And for those of you listening who want to dive into all the details yourselves, we've included a link to the full study right there in the description for this deep dive. If you found this exploration insightful and want to stay up to date on the latest research we unpack, please be sure to follow our show.
Yeah, that'd be great.
And if you have just a moment, leaving us a 5-star rating really helps other colleagues discover this content. We appreciate it.
So this study really raises a pretty important question for our field, doesn't it? Could this kind of combination therapy eventually become, maybe not the gold standard immediately, but a new standard of care in managing childhood myopia?
That's the big question.
And if we can consistently achieve these kinds of results in slowing axial elongation, what are the long-term benefits going to be for our patients' vision and their overall ocular health? It's certainly an area we'll all be watching with great interest.